The following podcast is part of a certified educational activity titled Addressing the Burden of Polyarticular Juvenile Idiopathic Arthritis, a roadmap to improving early diagnosis and treatment to maximize long-term outcomes. Access the entire activity and complete the post-test at peerview.com/DXP860. Downloadable additional resources are also available.
Hello, this is Dr. Daniel Lovell from the University of Cincinnati School of Medicine and Cincinnati Children's Hospital in Cincinnati, Ohio. Welcome to this unique educational activity focusing on strategies to improve the early diagnosis and treatment of polyarticular JIA. Dynamic animations and a video will be used to highlight the pathogenesis of polyarticular JIA and the rationale for therapeutic targeting. And a video of a patient from my practice and her mother will exemplify the impact of this disease on our patients' quality of life.
So it was President's Day, and Adele kept asking, up, mommy, up. And we kept picking her up. And I was starting to get a little frustrated because she wasn't being very independent. Now, of course, she has an older brother and sister. And so they were pretty, mobile and independent at this time. So one morning I was kind of frustrated with her after I changed her diaper. I said, nope, you are walking out to the living room by yourself. And she wasn't coming out. And I turned around and heard her going, mommy, mommy. And she was totally bent over at her waist, holding onto the wall, and her legs were shaking. And I picked her up and just remember her tapping me on the cheek saying, it's okay, mommy, it's okay. So I called the pediatrician. And I have a good relationship with my pediatrician. And she, I told her, I said, something's wrong. I know we were just in there, but something's wrong. So she had me come in. We went in and she said, okay, I'm going to do a series of x-rays. Go to the hospital, get them done, and do not leave until you talk to me. Went to the hospital, had a whole bunch of tests ran. And I got on the phone with the pediatrician while I was down at Children's Medical Center, and she said, Kay, nothing's wrong. And I remember saying to her, Dr. Gelford, I do not have Munchausen. Something is wrong with my daughter. So she said, okay, if it doesn't get better by next Friday, let me know. And it didn't get better. And I remember calling my husband and saying, you need to call and tell them that they're going to see us at the hospital today because something is wrong and I don't know what it is. So once my husband called the pediatrician, she had told me to call our orthopedic pediatrician at Children's Medical Center. And they had given us a date of March 8th. Which of course for me was not acceptable. And luckily, we went in and saw the orthopedic surgeon, and he saw Adele and he knew right away. Let me say he had a good inkling right away. He said, it's either arthritis, leukemia, and I can't remember the third one. Those two stuck in my mind. And he said, I want you to go have blood work done, but I don't want you to read anything on the internet, which was very funny because this diagnosis happened in 2007. So you can imagine all the stuff on the internet back then too. So we had her blood work done on a Wednesday. And on Friday, I was picking Adele up from preschool, and my phone rings, and it's the orthopedic, and they said, please hold the line for the doctor. And I remember thinking, this isn't good because the doctor's calling me directly. And I remember him telling me a whole bunch of numbers, and I didn't know what they meant. And I just, everything was happening so fast. And I remember saying, okay, I don't know what you're saying to me, and I just need you to tell me what to do. And he said very clearly, you will do nothing. My nurse is going to take care of all of the appointments, and I need you to be at the rheumatology, the pediatric rheumatology department on March 8th. I'll never forget that day. And I need you to be there. And I said, we will be there. So we showed up to the rheumatology department, and we were there for 3.5 hours. We saw OT, we saw PT, we saw a nurse, of course, and we also had a fellow that was with us at that time. And then we had our pediatric rheumatologist come in. And every time I tell the story about that appointment, a couple things come to mind. By this time, I had gone on the internet and I had looked everything up, right? And I was convinced Adele had 4 joints affected. So I thought she had Polyarticular JIA. And when the rheumatologist came in and he started writing the joints down on the whiteboard, she had 10. That was a hard day because I remember thinking, how could I be a mom and missed all of this, right? So the best thing about the appointment was that they listened to everything we said. And at the end of that 3.5-hour visit, we had a plan. I didn't really know how it was going to go. I wasn't really sure about the plan, but we had a plan because the 2 weeks before were very hard waiting for that appointment because I didn't know what that held for my daughter. When you're a parent, you dream of your daughter being being in ballet. You dream of them being a cheerleader or in gymnastics or a volleyball player, but I didn't know what her future held, right? So at least I had a plan, and I felt comfortable. And after 3.5 hours, we walked out of the pediatrician's office, and my husband said, well, I know that isn't what we wanted to hear, but how are you feeling? And I remember telling him, it's not what I wanted to hear, but I feel confident in these doctors, and I know they'll get us where we need to be. But we started on methotrexate, and she was also taking naproxen. And during that first year, we would have a good visit, and then we would have a bad visit, and then we would have a good visit, and then we would have a bad visit. Ultimately, we ended up going on to a biologic, and that was really hard because Adele then had to take 2 shots a week. So I remember the impact it had on our family. When it came time for shots, the boys would start acting silly. They were trying to, make her laugh. The face look on Adele and just the anxiety for my husband and I, it was just something that most kids don't deal with. And Adele was always a trooper. I mean, she is the strongest person I know. She's very strong.
So I think it was more like a big part of my life when I was younger because I had more flare-ups. We hadn't found the right medicine for me yet. And it was just, I was a lot more active, I think, like more like running around every single day type stuff. And my arthritis wasn't quite under control yet. So I think it was harder back then. And now, well, I've never lived without arthritis, so I don't really know what it's like to not have arthritis. But I talked to some teenagers with arthritis who had been diagnosed later, and they were talking about like all these different things that they could do before and that they couldn't do now. And I was like, well, I've just always been never able to do that. And it was really weird to me to see how much it actually changed. But I feel like now, since we found the right medicine, it's under control. I feel like it's more of a background now.
So juvenile idiopathic arthritis is one of the most common chronic diseases of childhood, with an estimated prevalence of 1 per 1,000 children. The term juvenile idiopathic arthritis, shortened as JIA, actually defines a heterogeneous collection of several inflammatory arthritides, all of which have an unknown etiology, with the disease onset prior to the age of 16 years, and a requirement that there be a minimum of 6 weeks duration of objective arthritis. The requirement is also to exclude other known causes of synovitis in children. Polyarticular JIA was formerly called polyarticular onset juvenile rheumatoid arthritis, but now it's called polyarticular JIA. It's a subset of overall JIA that's defined by the presence of more than 4 joints with active arthritis during the first 6 months of illness. Polyarticular JIA is more frequent in females than males, and there's a bimodal distribution of age of onset, with the first peak between the ages of 2 to 5 years and the second between 10 to 14 years of age. But it's important to remember that polyarticular JIA can actually start at any age less than 16 years of age, but it's very uncommon in children less than 2 years of age. When polyarticular JIA presents in younger children, and this is defined as children less than 10 years of age, it often looks very similar to oligoarticular JIA, with just 1 or 2 joints affected at the beginning of the disease, and it may become more active due to an intercurrent infection or other physical stress, and then this increases the number of active joints. Once you get to 5 joints or more, then that's the more severe part of the disease, and the disease tends to remain active in the joints that are involved, and a number of joints can markedly increase over time. The joint involvement is usually symmetric, with the knees, wrists, and ankles being the most frequently affected joints. When polyarticular JIA presents in older children, 10 years of age and older, including adolescents, these patients usually have a more rapid onset of inflammation of multiple joints, and it's far more likely that the small joints of the hands and feet are involved at the beginning of the disease. The diagnosis of juvenile idiopathic arthritis is one of exclusion. So other causes of joint inflammation in children must be eliminated before you can establish the JIA diagnosis. Shown here are some of the more common causes of joint inflammation or swelling in children, and include the other rheumatic diseases such as lupus, mixed connective tissue disease, vasculitis, that can present with joint involvement. Unfortunately, there's no specific diagnostic test that can be done that, if it's positive, establishes JIA. Diagnostic testing is really to establish other causes of joint pain and swelling in children. To introduce the treatment portion of the talk, it's important to remember that before the introduction of highly active therapeutics such as biologics, children with JIA very often experienced a diminished quality of life in adulthood because the arthritis caused irreversible damage to the joints for many children that carried into adult a burden of pain and disability from decreased function in the joints. To be able to reliably assess outcomes in clinical trials, a core set of outcome measures were developed based on consensus technique and analysis of prospective trials in children with JIA. As a result of that work, there are 6 measures that have been included in the core set of outcome measures for clinical trials in JIA. These 6 core set measures are then combined into validated definitions of improvement for children with JIA in clinical trials. Shown here are examples of levels of improvement. The most commonly used one in clinical trials of JIA is the ACR pediatric 30 level of response, which requires that at least 3 of the 6 JIA core set measures improve by 30% or more, and no more than one of the remaining measures worsens by more than 30%. Shown here are the FDA-approved non-steroidal anti-inflammatory drugs for use in juvenile idiopathic arthritis. Here is a clinical trial in which celecoxib was compared with naproxen in a prospective double-blind placebo-controlled study. The children involved in this study were primarily oligoarthritis patients. But what you can see is, using the aforementioned definition of response, that some children with NSAID monotherapy can demonstrate higher levels of response, such as an ACR pediatric 50 and an ACR pediatric 70. But the number who reach an ACR pediatric 70 level of response is around 30%. So for that reason, NSAIDs are often used as initial therapy, but very quickly in children with polyarticular disease, other agents are introduced. Shown here is the first 20 plus years of work of the Pediatric Rheumatology Collaborative Study Group, in which a number of prospective, double-blind, parallel studies were done in children with polyarticular JIA. In these studies, patients are randomized to either placebo or the active agent and remained in that treatment arm for 6 to 12 months. The drugs shown here, hydroxychloroquine, D-penicillamine, and Aranophen, were drugs that were commonly utilized in children with polyarticular JIA based on clinical series and open label results, but when tested in a double-blind placebo-controlled fashion, did not show any benefit over placebo. So if you look at the percent change in joint severity score, with a bigger percent decrease being greater improvement in the patient, then none of these drugs actually was better than placebo. And in fact, methotrexate at 5 milligrams per meter squared per week given orally, shown in the bright blue line, was also no better than placebo. It's only methotrexate at 10 milligrams per meter squared per week that clearly distinguished itself from placebo. So in the pivotal study of 2 doses of methotrexate given once weekly orally versus placebo, you can see the response rates for 5 milligrams per kilogram per week and placebo were essentially the same. It's only when you went to 10 milligrams per kilogram per week did you see a statistically significant response rate with methotrexate. So cytokines are central to the pathogenesis and disease manifestations of juvenile idiopathic arthritis. And what happens in children with chronic arthritis is that there's an imbalance with an overexpression of the pro-inflammatory cytokines and an underexpression of the anti-inflammatory cytokines.
Synovial membranes of patients with juvenile idiopathic arthritis, or JIA, contain activated T and B cells, plasma cells, and activated macrophages that are recruited via an intense neovascularization process. Host tissue cells, including activated synovial fibroblasts, chondrocytes, and osteoclasts, mediate cartilage and bone destruction. Although we still do not understand the exact cause of JIA, it is now known that 3 molecules, TNF-alpha, IL-6, and IL-1, are the major factors that keep inflammation in the joints active. This has led to the development of several new, very effective drugs. TNF inhibitors, including etanercept, adalimumab, golimumab, and infliximab, often provide rapid control of otherwise disabling arthritis, restoring quality of life and preventing further joint destruction. However, they are associated with an increased risk of infection. There were initial concerns about a possible association between treatment with TNF inhibitors and malignancy, but subsequent data have suggested that the risk of malignancy is associated with underlying JIA rather than the medications. Another biologic agent is tocilizumab, a humanized monoclonal antibody against the IL-6 receptor that is approved for the treatment of moderate to severe polyarticular JIA in children ages 2 years and older. It has been used in clinical trials in children who are refractory or intolerant to methotrexate. Both IV and subcutaneous administration of tocilizumab are US FDA approved for polyarticular JIA. Abatacept blocks T-cell co-stimulation, which interferes with pro-inflammatory messages being passed to and from T-cells. Subcutaneous abatacept is approved by the US FDA for the treatment of moderate to severe polyarticular JIA in children ages 2 years and older. Intravenous abatacept is approved for use in moderate to severe polyarticular JIA in children ages 6 years and older. Tofacitinib, a Janus kinase or JAK inhibitor, was approved by the US FDA in 2020 for the treatment of polyarticular JIA. Janus kinases belong to the family of tyrosine kinase enzymes recognized by their ability to phosphorylate tyrosine residues, altering the function of the protein that they are contained in. They are able to transfer extracellular signals from cell surface receptors to the nucleus, changing DNA transcription and the subsequent translation of proteins. The JAK-STAT pathway operates downstream of more than 50 cytokines and growth factors and is regarded as a central communication node for the immune system. There are 4 members of the JAK family: JAK1, JAK2, JAK3, and TYK2. Each cell surface receptor requires a pair of JAKs as either identical homodimers, for example JAK2, JAK2, or heterodimers, for example JAK1, JAK3, in order to signal. This in turn activates STAT proteins, signal transducers and activators of transcription, which, as their name suggests, target gene promoters to activate transcription. Because of their central role in the immune response and their association with several cytokine receptors, the inhibition of JAKs appeared to be a promising strategy in autoimmune diseases.
We'll now turn our attention to biologic therapies, which have revolutionized the outcomes and treatment expectation for children with juvenile idiopathic arthritis, especially those with the polyarticular forms of JIA. In almost all of the randomized studies of biologic agents in children, we used a randomized placebo control withdrawal design. This was done because it became apparent that with continued active disease, patients continue to accrue damage to the joint and have impairment in their quality of life. So we wanted to come up with a study design that minimized the requirement for children to remain on placebo and to allow children who demonstrate a worsening of their disease to come off placebo and get back on active treatment. The first biologic to be studied in this format was etanercept. And what's shown here is what happens to the children in the trial through the various phases of the study. So shown here are only the patients who demonstrated response in the open label portion of the study, so that it represents 100% of the patients who are having data demonstrated, whereas only about 85% of the patients demonstrate an ACR 30 level of response. But the purpose of this slide is to show what happens during the course of this study design. So in the open label portion, patients demonstrate response. In those who demonstrate response, they're randomized to either continue the drug or go on placebo. You can see in this part 2 of the study, there was a very rapid separation of the two groups. And by the end of the blinded portion of the study, there was a clear delineation of the proportion of patients who had lost the response. And then in the patients who were treated with placebo, shown in gray, upon retreatment with the active agent of etanercept in the open label extension portion of the study, they very quickly regained response, and the level of response was similar to those patients who had continued etanercept throughout the course of the study. The primary outcome measure for this study design is either the number of patients who demonstrate flare compared in the two treatment groups, or the median days to flare. For both of these outcome measures, you could see there was a strongly statistically significant difference comparing placebo to etanercept, with far fewer patients who continued etanercept demonstrating flare during the double blind, and the median days to flare was much shorter for the patients on placebo. This is data from the open label extension portion of the study. All patients are being treated with etanercept, and what's shown in the x-axis is the number of years they remained in the study on treatment with etanercept. And you can see that eventually about 30% of the patients demonstrated an ACR pediatric 100 level of response, whereas about 70% demonstrated an ACR pediatric 90 level of response. It's important to note that this is an as-observed analysis, so that only patients who remained on treatment and continued in the study were included in this analysis. Here's a randomized placebo-controlled trial of infliximab plus methotrexate compared to placebo for polyarticular JIA. This is the only biologic study in which a traditional parallel type design was used, so that patients were treated with placebo through the first 14 weeks of the study, and 14 weeks was the primary time point for efficacy analysis. And they were compared to patients who had been treated with infliximab 3 milligrams per kilo through the first 14 weeks of the study. At the end of 14 weeks, the patients who had been on placebo were then started on 6 milligrams per kilo of infliximab, and patients were followed through 52 weeks on either 6 milligrams per kilo of infliximab versus 3 milligrams per kilo of infliximab. At the end of 14 weeks, the patients on placebo had lower levels of response on the various levels of response here. And then once the children on placebo got put on 6 milligrams per kilo, the level of response quickly mirrored that of the children who were on 3 milligrams per kilo. This study failed to meet its primary endpoint at 14 weeks for a variety of reasons, one of which was the fact that we were very hesitant to enroll children in a traditional parallel design, and it turned out the placebo response rate was higher than predicted. But you can see that with treatment with either dose level, children demonstrated high levels of ACR 30, 50, and 70 level response through the 52 weeks. And here's the long-term extension data. In this patients on infliximab, all patients were being treated with infliximab at this point in time. This again is an as-observed population, but you can see that between 40 and 50% of the patients demonstrated an ACR pediatric 90 level of response, and even higher levels of response for the less stringent definitions of improvement. There was a similar randomized withdrawal design of adalimumab in patients with methotrexate. What was shown in that study, in the open label portion of the study in which all patients received adalimumab, then the response occurred quickly, and patients had high levels of various JIA responses, similar to what's been seen with the other anti-TNF agents in polyarticular JIA. And the study met its primary outcome measure in the double-blind randomized portion of the population. Subcutaneous golimumab was assessed in children with polyarticular JIA, again using a double-blind randomized withdrawal trial design. At 4 weeks of treatment, you can see the majority of the patients had already demonstrated response at ACR 30 and 50 levels of response, and with continued treatment, there was an increase in a proportion demonstrating response, so that at the end of 16 weeks of open label treatment, about 20% of the patients demonstrated clinically inactive disease. Shown is the results of the double-blind withdrawal portion of the study. And what you can see is that there was not a clear-cut distinction between the patients who were randomized to continue golimumab versus the patients who were randomized to switch to placebo, as the response rate continued to be high in the patients who were randomized to continue placebo, even through 48 weeks of treatment in the double-blind. So the study failed to meet its primary outcome measure. Abatacept was studied in children, again with the randomized double-blind placebo-controlled design. And what you can see is that there was high level of response to abatacept in the open-label lead-in portion of the study. And the study met its primary endpoint in the double-blind with significantly more patients with placebo demonstrating flare during the double-blind than patients who continued on abatacept. And what you can see is the overall response rates were higher in patients who were biologic naive at the time they started abatacept versus those patients who had failed a prior anti-TNF therapy. So response was seen in those patients who had failed a prior anti-TNF, but was at a lower frequency. And most important, at higher levels of response, very few patients who had failed prior TNF therapy demonstrated these higher levels of response on abatacept. This is the results from tocilizumab in polyarticular JIA. And you can see again that at 4 weeks, over half of the patients had already demonstrated 30 and 50 levels of response. And with continued treatment, the response rates climbed. So at the end of 16 weeks of treatment, approximately 25% of the patients demonstrated ACR 90 level response. Shown on the right is a result from the double-blind withdrawal phase, and again, met its primary endpoint with significantly more patients randomized to placebo demonstrating flare. The most recent study was of tofacitinib in polyarticular JIA, and again, this was a phase 3 randomized withdrawal design. Based on this study, tofacitinib was approved by the FDA for the treatment of polyarticular JIA in September of 2020. Shown on the left is the responses during the 2 phases of the study. So the first block on the left shows a response in the patients on tofacitinib in an open label fashion. You can see that over 80% of the patients demonstrated an ACR 50 level response during the first 18 weeks of open label treatment. And then shown on the right is what happened with these patients during the double-blind portion of the study, with the patients in placebo being in a dotted bar. And you can see that there started to be separation of the response rate by week 24 of the double-blind. This is the primary outcome measure for that study, and you could see that there was a strong statistically significant advantage to continuing on tofacitinib with fewer flares in the double-blind. And shown on the right is a Kaplan-Meier curve of time to disease flare in days in the double-blind. And you can see that the 2 treatment arms start to separate after about 40 days in the double-blind. Shown here in the tofacitinib study is change in the JDAS over time. So at the beginning of the study, the mean JDAS 27 CRP score was 22.6, which demonstrates very high disease activity. And by the end of 18 weeks of open label treatment, the mean was 6.4, which puts the patients down to moderate disease activity. And you can see with continued treatment with tofacitinib that the mean came down to 3.6, which was equivalent to low disease activity. Here's the effect on patient-reported outcomes with tofacitinib treatment over time. And you can see that the parent-patient assessment of the child's pain decreased over time in the open label and treatment. The same thing was seen for overall well-being. So that improved during the course of the open label extension. And then shown on the right is what happened during the double blind. And you can see for those children who continued on tofacitinib that continued to improve over time. So at the end of the double blind period, the mean pain score for the tofacitinib patient was 1 out of 10. And the overall disease well-being was 1 out of a possible score of 0 to 10. Tofacitinib was provided to the children in the study as either a pill, 5 milligrams, or an oral solution. And we did a taste survey in those kids who took the oral solution, and they found it to be acceptable. We now look at the 2019 ACR treatment guidelines for children and adolescents with polyarthritis. It's important to note that for the ACR treatment guidelines, they did not express the conclusions based on ILR diagnostic criteria, but rather grouped different ILR subgroups into those who had polyarthritis either at onset or during the course of the disease, compared to patients who had persistent oligoarthritis. And what you can see is that methotrexate was recommended as the initial therapy. In patients who had low disease activity with methotrexate therapy, then it was recommended to escalate therapy, either to use steroid injections or to add methotrexate if it hadn't been used, or to add biologic if it had been used. This was a departure from prior guidelines, which demonstrated that there was no tolerance for even ongoing low disease activity. The presence of any disease activity warranted escalation of therapy because the acceptable outcome used in the guidelines was clinically inactive disease. For patients who had moderate disease activity after start of methotrexate, then it was recommended to add a biologic. And in kids who had risk factors, it was recommended to start initial therapy with biologics if possible, or to introduce it into the treatment of the child very quickly. And again, for patients with low disease activity, but at least one joint with active arthritis receiving a biologic treatment or traditional DMARD, the recommendation was to do something to improve overall treatment control, whether this represented a joint injection if it was just a single joint, or escalation of the systemic therapy if it was more than one joint. Recently in JIA, the concept of treat to target has been introduced. The recommendation is that the primary target for treatment should be clinical remission, which means the absence of signs and symptoms of inflammatory disease activity, including relevant extra-articular manifestations such as uveitis, psoriasis, and systemic aspects of the disease in systemic JIA. In patients who have long-standing disease, then minimal or low disease activity may be an acceptable target. Setting the target, selecting the tools, and the treatments should be based on the patient's characteristics, and again, agreed upon with the patient and the parents. The key to treat to target is that you regularly assess and document the outcome of the child using a validated composite instrument of disease activity. The frequency of doing this assessment depends on the category of the disease, level of disease activity, and the extra-articular manifestations. At each time you assess the status of the child, if they don't reach the target, then the treatment should be adjusted. This is the essence of treat to target, is you change the treatment as required to keep moving the child towards achievement of the target. And then once you reach the target, then it's important that you maintain the child in achieving that target ongoingly, so that you look at the maintenance therapy to maintain the child at the target level of improvement. So in conclusion, for all JA categories at this time, there still is an unmet medical need. Greater than 15% of JA patients are chronically unresponsive to all the available treatments, and many have tried and failed multiple biologics and still failed to demonstrate inactive disease or adequate response, or been unable to maintain that level of response even though they may have achieved it initially. The JAK kinase inhibitors represent promising treatments for JIA. One is they have a novel mechanism of action for developing the improvement in the patients compared to other available treatments for JIA. There's demonstrated efficacy in polyarticular forms of JIA. Patients and parents appreciate the fact that this is an oral administration, and you can use either tablet or solution based on the ability of the child to swallow pills. And it's clearly preferred over injections or infusions by both children and parents. And so far, with JAK kinase inhibitors, there's been a low potential for immunogenicity. This ends our discussion for today. I hope you found the activity informative and useful to your practice, and encourage you to access the supplemental materials. Thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/DXP860. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. This activity is supported by an educational grant from Pfizer. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.